Hello and welcome to Pulse Check with Archer Nursing, where nursing comes to life. In this podcast, you give us 15 minutes of your day, and we'll take one complicated nursing topic and make it easy. Ready for nursing to be fun? I'm Morgan, and today we're tackling postpartum hemorrhage. As always, let's kick things off with our practice question. A nurse is caring for a postpartum client 45 minutes after a vaginal delivery. The client reports feeling lightheaded, and the nurse notes a saturated perineal pad within 10 minutes. On assessment, the uterus is boggy and palpated above the umbilicus, deviated to the right. Which of the following actions is the priority for the nurse to perform? We have A, administer oxytocin as prescribed. B, massage the uterine fundus firmly. C, assist the client to the bathroom to void. Or D, obtain a stat, hemoglobin, hematocrit, and type and screen. All right, save what you think the right answer might be. We will circle back to the correct response at the end of the episode. But first, we are going to zoom in on that normal postpartum body and anatomy, look at what is supposed to happen, and then what can cause and what happens with a hemorrhage. Really, what should happen after a vaginal delivery is the placenta gets delivered, and this leaves behind a giant raw area inside the uterus. And that is where all those placental vessels used to connect, because we know the placenta is basically the pathway for blood to go from mom to baby and baby to mom. So it's really juicy, lots of vessels. It has to pretty much rip off the wall of the uterus to get out. That leaves behind a wound. And if that sounds like it should bleed a lot, you are correct. Unless the uterus does what it's supposed to do, it is going to bleed a lot. What the uterus normally does, which remember is a very, very strong muscle, is it clamps down. It contracts hard. Picture like a hand squeezing a bunch of open straws. Open straws are those vessels bleeding, bleeding, bleeding. Uterus clamps down, compresses, and basically shuts them off so that those blood vessels don't hemorrhage. We don't bleed a bunch. The uterus is kind of acting like a living tourniquet, it's putting pressure, and that is the main way that our bodies are designed to prevent hemorrhage after birth. So in a postpartum hemorrhage, somehow, some way that tourniquet effect fails, or something else is bleeding that the uterus can't fix. So clinically, you are going to hear the 4 T's. I'm not going to list them out like a worksheet or anything. I don't care if you remember that. I just want you to get an idea of those different things. 1 is uterine atony. That's our first T. And that basically means the uterus is tired, it is overstretched, it's asleep at the wheel, and it stays soft instead of firm. So the first T, atony. Second one is trauma. That's going to be, anything traumatic, a laceration, maybe of the cervix or vagina, maybe a hematoma. Bleeding can be really, really heavy here, even though the uterus is doing its job and the fundus is rock solid. So that's our second T, trauma. The third is for tissue. So retained tissue usually means a fragment of the placenta broke off and is still inside. And that is going to keep the uterus from fully contracting. It's kind of like a pebble stuck under a door that just won't close. We can't fully clamp down when that little fragment is left behind. And that's one of the reasons post-delivery, we really need to look at that placenta and make sure the entire placenta was delivered. So that's the third T, retained tissue. And lastly is thrombin. Thrombin is one of the things in our body that helps us clot. And if we don't have enough of it, we can have a clotting problem. So everything else can be normal, like the uterus is contracting down, there's no retained tissue or trauma. But if we don't have thrombin, we cannot clot, and even normal amounts of bleeding can become dangerous really, really fast. Now, I'm going to spend a little extra time on that first T, uterine atony, because that is the most common cause and what you really need to know as the nurse for how to act. So, backing up, during pregnancy, the uterus stretches massively. If it stretches too much, think like multiple gestation. We have twins or triplets in there. Polyhydramnios, a ton of fluid. Maybe a macrosomic fetus, a baby that is really, really large. Or perhaps the uterus has been contracting for a really long time and just gets totally exhausted. In either of those instances, we've stretched too much or we've clamped down for too long and we can't do it anymore. It leads to the uterus just not having the tone needed to clamp down after delivery. Remember, the uterus is a muscle, a really strong one, and it needs that muscle tone to clamp down on those vessels and stop the bleeding. So think about like a rubber band that's been stretched and stretched for 9 months, and then boom, it's got to snap back. And if it doesn't snap back, those vessels are wide open and we get a lot of bleeding. So that's just the first T, uterine atony, but that's what we're going to kind of really talk about today in our case study, because most often you're going to see atony leading to that postpartum hemorrhage. One other little bit of patho before we move on to the story, though, is the bladder. A full bladder is going to push the uterus up and to the side, usually to the right, just based on where those organs are located. And that displacement is going to make it a lot harder for the uterus to contract down like it needs to. So that is why women are typically told they need to get up and pee within an hour of delivery. Otherwise, potentially, we might consider using a catheter to make sure that bladder is empty. We don't want it pushing the uterus up and displacing it, because that impairs its ability to clamp down and prevent that hemorrhage. So that is the basic anatomy behind what the uterus should be doing and what happens when it doesn't and we get that hemorrhage. So we'll flip into story time and walk through a little clinical scenario here. This is one of my favorite stories to tell because it was my first night as a nurse. So my very first shift ever, like totally on orientation, just my very first night, like not in school, not in a clinical. Night shift on a mother-baby unit at a regional hospital. Okay, me and my preceptor, of course, had, I want to say, 4 different postpartum mothers and their infants. We took care of them as dyads, so you had both the mom and the baby. I really loved mother-baby, by the way. It is a cool way to get different types of specialty care. You learn a little pediatrics, newborn, you get to do all of that stuff, and then also the postpartum stuff with mom. So really, really interesting area to get into. But all that aside, all 4 of these mamas had successful vaginal deliveries. Everyone we were caring for that night was pretty healthy, not really expecting any complications. So my one client, who I don't remember her name anymore, but she was the most recent delivered. She had delivered about a half an hour before shift change. So we went in to assess her first, get the vitals and do her assessment and just, make sure things were going okay in there. So we go in, introducing ourselves. I'm like, I'm Morgan. I'm going to be your nurse this evening, which feels so cool because it's literally my first night being able to say that and say I'm not a student. And we start, with that across the room assessment, kind of looking, seeing what we see. So she looks pale. She does not look like she feels good. She's a little glassed over. She's like, I just feel weird. Now, granted, she had just given birth, so I'm like, maybe that's how people look right after they give birth. Maybe that's okay. So my preceptor pulls the covers back, and she is sitting in a pool of blood. This is not just like I've saturated a peri pad, like she's in a puddle. So my preceptor, who's very well seasoned, knew exactly what to do. I had no idea what to do. Immediately hit the call bell to get some more hands in the room and went straight to the fundus, so that uterus. She palpated and said, hey, your uterus feels boggy. I'm not going to lie, I don't think I had heard that word before, boggy. It's a little bit hard to describe what a boggy fundus feels like. The best I can think of is maybe like a squishy water balloon. And it's usually up really high. The uterus isn't shrinking down where we think that it should be. What we want to feel is a really hard, contracted fundus. We want that uterus clamped down, cutting off those vessels. But as my preceptor is palpating and she's grabbing me, pulling me into this, she's like, okay, this is what a boggy uterus feels like, pressing down like it's soft and squishy. And she could tell it was also shifted off midline. So likely her bladder was full, kind of playing into this at the same time. So priority actions. She is actively hemorrhaging. We have uterine atony. You do two things pretty much at the same time. First, firm fundal massage. When I say firm, this is not a gentle pat. This is going to hurt. You're going to say, I'm so sorry. This is not going to feel good. But we are going to dig into that uterus. We need to wake that uterus up and say, it is time to clamp down right now. And we are massaging and trying to get that fundus to really firm up with our hand. Remember, again, goal is firm midline uterus. While you're doing that, you call for help. You get more people in the room. We do eventually want to get her bladder empty. Right now, it is not safe for her to stand up and go void. In a hemorrhage situation, we are often going to quickly do a straight cath so that we can just resolve that full bladder. We don't necessarily need to leave like a continuous catheter, like a Foley catheter in, but we do want to just get that bladder empty. That'll help make our fundal massage more effective. Now, what are you assessing for while you are massaging the fundus and the rest of your team is getting into the room? I want you to laser in on your vitals, and I want you trending those vitals. Now, being that we were in Mother Baby, we did not have her on a continuous monitor. I think about this later in my career as like a decade later. I've spent all my time in the ICU where I know like every number about everybody all the time. But, in Mother Baby with normal healthy deliveries, you're not like hooked up to a vitals machine all the time. So somebody's going to want to get her on the monitor because I want to see that heart rate. If it is climbing, she's getting more tachycardic, and particularly with a dropping blood pressure, I start to worry about shock. Postpartum hemorrhage can lead to hypovolemic shock. Other things you're watching with your eyes are her demeanor, her level of consciousness. Is she anxious, sleepy? What does her skin look like? Cool, clammy? Or is it nice and warm? How are her pulses? If they are getting weak and thready, we're having delayed cap refill. All those things pointing towards poor perfusion make us think we're heading towards shock. And that is the worst case scenario. We really do not want to get there. We want to stop this bleed before they enter shock. That being said, it's not like fundal massage magically fixes everything right away. So when my preceptor hit that call bell and started getting more people in their room, the next action that a nurse took was getting IV access. This mom had had a natural delivery. She did not have an IV already in place. Some moms will, but in this case, when they're hemorrhaging, while we are trying to get that fundus to firm up, we want to get IV access because we might need fluids to help get that volume up. And we also might need medications or potentially even blood products if we do bleed too much. So the very wonderful and smart nurse that started that IV did go ahead and draw labs when she was starting it. She wanted a CBC to see what the H&H was, that hemoglobin hematocrit, and also wanted a type and screen because if things get ugly, we want to be ready to get blood products as quickly as possible. So we're doing a little pre-work here to make sure that we're all lined up and ready to go. Okay, so we've got that IV. We sent those labs off. My preceptor is still massaging the fundus here. And it's probably been no more than 5 minutes. When I think back, it felt like so much longer than that. But everyone is doing things so quickly. The provider is at the bedside now. We're assessing those vital signs. And she makes the call to go ahead and start a medication to get that uterus clamping down. She is still actively hemorrhaging. We need to help that uterus stop that hemorrhage. The first line medication that we usually use here is oxytocin. Oxytocin, I think of it as like the uterus's like hype girl. It makes everything stronger and more frequent. It is the natural hormone our bodies make when we're in labor and having contractions. Oxytocin causes a contraction. Baby gets pushed further down. That pressure on the cervix tells us to make more oxytocin, and we go in that positive feedback loop. So we want to get some of that nice juicy oxytocin in there to get the uterus to clamp down like it's supposed to. So that's going to be a quick go-to. I want to say they had this medication up and running within 5 to 7 minutes of this hemorrhage. They moved really, really fast. And for this mom, within that 10 to 15 minute mark, the bleeding wasn't stopped, but it was slowing down. And we were in a place where we didn't need to go further with medications. But there are cases where you're going to need additional uterotonics or things that are going to clamp down that uterus. One of those is methylgurbonamine. And that is really powerful for uterine contraction. But if your client is hypertensive or has preeclampsia, we try to avoid it because it can spike blood pressure. Another one is carboprost. That can help kind of crank the uterus down, but it can cause bronchospasm. So we try to avoid it in asthma. And then lastly, and this I've actually seen more commonly than either, is misoprostol. We often give that rectally for rapid absorption, and it's broadly safe. You'll want to watch for fever and shivering as common side effects, but it doesn't have specific contraindications like the methylguanidine for the hypertension and the carboprost for the asthma. So a little farm to throw your way to remember those different meds. But if you were going to have one takeaway, remember that oxytocin, and the synthetic form of that, the brand name that you're probably going to hear in real life, is going to be Pitocin. A lot of places, actually, when I got ready to deliver, it was actually postpartum protocol that they started everybody on Pitocin. So it's likely going to be at the bedside, ready to go, as that kind of first line, hey, if we start bleeding, we're going to turn on that Pitocin, get that uterus to firm up and slow the bleeding down. You as the nurse need to be laser focused on continuing to check that fundus, massage, make sure it gets firm in midline, keep that bladder empty. We usually try to at least somewhat quantify blood loss. The first way we do that is with like pad counts, but in this case, there was literally a puddle, and it was, we couldn't get an exact amount from that. So sometimes just saying, it was a puddle is enough to escalate care, and, we're going to worry about exact numbers later. Now, what would we have done? We just talked through a very typical postpartum hemorrhage case. I will mention that no one else on the mother-baby unit was fazed by this whatsoever. I was totally fazed. And when I was leaving that very first shift, my preceptor was like, so are you going to come back tomorrow? Have I ruined your nursing career? I was like, no, like it was great. I'm totally fine. But that was like a very classic, she had just delivered, her bladder was full, her uterus had that atony, it was all boggy. We did fundal massage, we gave Pitocin, like textbook case, and clearly they were very used to managing that. But she walked me through this exercise of, okay, if we had gone through all those meds, we gave Pitocin, we gave methylguanidine, we did misoprostol, we're doing the fundal massage, she is still hemorrhaging, and she's going into hypovolemic shock. She's tachycardic, she's hypotensive. That's when we have to start thinking about those other T's that we mentioned at the beginning of the episode. What if there was trauma? If there is a firm uterus and ongoing bright red bleeding, we might have a laceration somewhere, and the uterus is doing its job, but something else is leaking. So we need to notify the provider. They're going to come in and prepare to do an inspection and repair. and continued supportive access with that IV fluid and monitoring, etc. What if we do all these interventions and the uterus just won't stay firm? We still have atony. We need to think about retained tissue. Could there be an infection? We might prep to do an ultrasound to see if there is any tissue, or the provider might do manual exploration or procedures to try and see, hey, if you did retain placenta, we're going to try to get it out. And I will just drop one more time. Don't forget about that bladder. That can be a really simple fix to a boggy uterus, because if we do have a full bladder, it's going to push that uterus up and over to the right and just not let it clamp down like it's supposed to. So all that being said, it brings us back to our practice question, of course. Let's see now if you can get to the right answer and understand why. You are caring for a client who is 45 minutes post-delivery and they report feeling lightheaded. They have saturated a peripad within 10 minutes. On assessment, the uterus is boggy. It is palpated above the umbilicus and deviated to the right. Which of the following actions is the priority for the nurse to perform? We have A, administer oxytocin as prescribed, B, massage the uterine fundus firmly, C, assist the client to the bathroom to void, or D, obtain a stat, hemoglobin hematocrit, and type and screen. Now, this is asking for your priority. What are you doing first? Because I'll say right off the bat, we talked about all of these answer choices in our case study, and they are all correct. We are totally going to do these things. But the first thing that we are going to do is massage the fundus. B, massaging that fundus is going to help the uterus get firm and clamp down. Most of the time when we're hemorrhaging, uterine atony is the cause. The uterus ain't clamping down like it's supposed to. We are going to firmly massage to get it firm in midline. Wake that uterus up. Then we might move on to A, giving that oxytocin, that Pitocin. If it's safe to get them up and go to the bathroom to void, that's great. If we are actively hemorrhaging, more likely we're going to do a straight cath to get that bladder empty. And yeah, absolutely, get an IV and get those labs. But first, we prioritize treating the urgent problem of a boggy uterus that is not clamping down. Your priority action is addressing that boggy uterus. And really, that's the whole key takeaway from the episode. Think about the body. Think about how the uterus is supposed to be our tourniquet. It clamps down on those vessels. And if it's boggy, your hands are the first line intervention to go wake that uterus up. Of course, simultaneously treat the whole patient with rapid escalation. Uterotonics like that Pitocin. Make sure we're emptying that bladder and monitoring closely because we don't want them to go into hypovolemic shock. All right, future nurses, that is a wrap. If you found this pod helpful, I'd love to continue supporting your nursing journey through nursing school, the NCLEX, continuing ed, and beyond. Archer Nursing has you covered with on-demand video lectures, high-yield question banks, live case study reviews, and so much more. We want to help you master tough concepts and make it fun. So join us over at archerreview.com. Follow us on socials at Archer Nursing for more free nursing tips and study resources. Thanks for tuning in to Pulse Check with Archer Nursing. I'm Dr. Morgan Taylor, and I'll see you back next time.